what do we actually mean by making every contact count?
Receiving or getting all the services at any point of contact.
So tracking this makes sure that you're able to follow up a mother from pregnancy all the way to delivery.
Hi everyone, welcome to the See It Do It podcast series. See it means see linked data, and do it means act on the data.
Let's make every contact count.
Core concepts, quality improvement.
Doing things differently.
Mentoring, support, supervision, and coaching.
Client perspective.
Data quality, digitization.
We are See It, Do It. Welcome to the See It, Do It podcast series. My name is Vicky Doyle and I am the Quality Improvement Advisor to the See It, Do It programme. Today we're going to be talking about making every contact count. That's whether that contact is at the community level or at the facility level. And I'm delighted to welcome to the studio today two of our community health experts. So I'm going to ask you to introduce yourselves, please.
Thank you, Vicky. My name is Jared Odaro. I am a program officer with Lvcthealth. I work under See It, Do It program in Homa Bay, implementing See It, Do It. Thank you.
Thank you. And I'm Lynette Okoth. I work for Lvcthealth. I'm a senior technical advisor, community health, and glad to be here.
Yeah, delighted to have you here. Lots and lots of knowledge, expertise, and experience of actually trying to make things happen on the ground. Because we see lots of policy things happening, but actually it's how you implement it in practice that really, really matters. And so the provocation for today is, how can we achieve 8 ANC contacts when in many parts of the country, in Kenya, we're still struggling to even achieve 4 contacts? So it's quite a challenge. This is what a policy change, which was driven by policy change globally when WHO recommended that we should increase from 4 to 8 ANC contacts. And See It, Do It has been focused on trying to drive up to those 8 ANC contacts. So I suppose my first question to you both is, what do we actually mean by making every contact count?
Thank you, Vicky. I agree with you that it is quite a challenge. Making every contact count simply means receiving or getting all the services at any point of contact. For example, when a pregnant mother visits a facility, there are services that they are supposed to receive at first ANC, going down up to the 8th ANC. So when they visit, for example, that first ANC, are they able to get the profile done? Are all the services given to them, all the commodities? And also when they go to the community after being referred from the facility, because there is community facility referral and there is facility community referral. When they go to the community or to their household, when a CHP does a visit, are they able to deliver all the services that this mother requires? For example, health talks, and then performing things like ensuring that they are taught during their pregnancy and also given this health education, they are assessed well, and then being told what to do at that particular point. So it is about making sure that whenever they make a contact with a CHP or a community health promoter or a facility nurse, they get all the required services at that point.
Yeah. Maybe just to say that, maybe just to add that in the discussion around making every contact count, we have services aligned with every contact. So when you say achieving every or making every contact count, is that if they're supposed to have the ANC profile, then it is done at the right contact, so that you not have any contact delayed, because that then impacts on them achieving the 8 contacts.
Okay. Yeah. And I think what you're both saying is that there are missed opportunities if the health provider or the community provider doesn't maximise that contact time. That's a missed opportunity which could potentially affect the health of that expectant mother and even the pregnancy outcome itself.
Exactly.
Yeah. So maybe my next question is, why is it that we're not making every contact count? Because we've already seen by the figures that in many parts of Kenya, women are not going for 8 ANC contacts. Why is that? Why are we not making every contact count?
Yeah, and thanks, Vicky. Probably I'll take a first stab on this. Is that achieving, and rightfully said, that we struggled and we keep on struggling with the four ANC visits, or what we used to call focused antenatal care, FANC, and now we are pushing the 8 contact agenda. I would say that this is multifaceted. And my reasoning for saying this is that, and when you go back to look at the delays in maternal health achievement, is that we talk about 3 delays, and the first and the second delays are basically community delays. So is the mother or expectant mother aware that they're supposed to start their first ANC contact or first ANC visit? Do they make the decision to get to the facility? And when you talk about the community and the community, the first 2 delays is that we have so many things. Do we have infrastructure? How is the road to the facility? Do they have money that they kept to make them get to the facility? And that is for transport. Do they have a companion that is taking them there? Do they have clothes for their new baby? So those things come in the community. Then now in the facility, the third delay, and that's where there's a lot also happening. Do we have skilled personnel? Do we have all the commodities required? Is the facility open 24 hours? So it is multifaceted because there's so much that is happening from the time she got pregnant to the time she's supposed to go for ANC. And all these components must be addressed for them to achieve 8 contacts. So if anyone does an intervention, then we must consider all the components. Yeah.
So it's pretty complicated, isn't it?
Yeah, in addition to what Lynette has talked about, there is an aspect of community in it, what people believe. One of the things that usually happens, there are people who believe that when a pregnancy is at a certain stage, that they are not supposed to expose it, because if they expose it, it will lead to termination of the pregnancy. So it's all about how these people are brought up, their beliefs, the context of what she has talked about. All this brought together brings the delay in receipt, because it's not all about the people who receive the services. It's also about this person who is supposed to receive these particular services. Are they ready to receive the services? Are they willing to go and receive them? If they are not willing, then it means these contacts will not count. There will always be a delay at some point. Yes.
But we hope that we can tackle this and it's not beyond the structures and the systems that we have in place within Kenya. So maybe the next question then is to ask you, I know that in See It, Do It, they've been quite innovative. It's an innovative program, and you developed a new tool to track ANC contacts at the community level, because we know that before, CHPs are visiting households, but very little is recorded. And so we don't really know what's happening at the community level. So can you describe a little bit more about how you're tracking these ANC contacts now at the community level? And, and how does this work? What is this tool and how is it working?
Okay. Thank you for the good question. And this is one of our innovations as a program. The tool is called Community Household Antenatal Record Tracker. Chart in short form. So this chart tool is a tool whereby it is attached to a mother-child booklet. And once a mother is confirmed pregnant at the facility, when they are issued with a mother-child booklet, that tool is attached at the back. So when the mother goes back home with this particular tool and they are visited by a community health promoter at the household level, the community health promoter will look at they check on the services they received at the facility level. Then they will be able to record in that particular tool. If they are the people who actually identified this mother, they will fill the first page to show that they are people who actually identified how they did identify. If they identified through testing at the community level and all that, they will be able to record that. And then as they continue visiting, every month they will be able to see whether the mother was able to go to the facility as scheduled in their mother-child booklet and record. And also, there are services that they are providing for this particular mother at the household level. They're supposed to record those particular services. And then when the mother goes back with the book to the facility nurse will look at the book and then cross-check and see actually that this mother was visited by a CHP or a community health promoter, and that will only be shown by this community health promoter filling in this book. The facility nurse will fill and then put a rubber stamp so that the track continues, so that we don't miss any contact at any level.
So basically then this is recording the whole pregnancy journey.
Yes.
Yeah. And what's the benefits of this, Lynette?
Yeah, I think the benefit is that pregnancy is actually a longitudinal indicator. So tracking this makes sure that you're able to follow up a mother from pregnancy all the way to delivery. And it gives us an opportunity to actually tell some of the gaps that happen at the CHP level and at the facility service provider level. So then that informs us on doing a targeted sensitization, targeted training, because then based on the documentation, you're able to pick the gaps. And so you're only intervening in the gaps that are identified. Yeah. And it also gives the CHP an opportunity to showcase their work. I think a CHP is one of those heroes who've always worked for the longest time. And at times it's very difficult to justify or show what they're doing. And I think we also made a lot of assumptions that they might not be able to interpret or document. So now we're using chat as a tool to actually show that a CHP can actually document. First, they know what they are doing. They can document, and they can use this to inform quality improvement initiatives. So then that makes it a proper tool to be used with the government. And the good thing is it's part of the mother-child booklet that both community and the facility are able to look at together.
Okay.
Actually, that tool has helped us to achieve. Remember when you were starting the conversation, we said it was a problem. It was a tall order to get 4 ANC visits. Now we are at a level whereby we are able to track the many mothers up to eight contacts using that tool. And then in many of our facilities, we are up at about 70% of the level of mothers who are attending 8 contacts and beyond. So it's a good tool. It's one of the tools that has really made our work easier.
So you've already preempted my next question, because we have seen now that some of the facilities are getting to almost 70% of all pregnant mothers are achieving 8 ANC contacts, which is a huge achievement. And so, how have they managed to achieve this? What's been the secret? Because it looks like they're making every contact count.
I don't know whether Lynette wants to go first.
Yeah, so probably just to say that what has made us achieve 8 contacts is at the point where we get in touch with the mothers. So chat plays a very critical role. Electronic community health information system plays a critical role because CHPs are able to enroll all household members in niches. So then that is able to track mothers who could be pregnant in the community. And this gives them a prompt to ask them questions about whether they're pregnant or not. And additionally, we're able to train our CHPs to be able to do community pregnancy testing. And what we've learned from our study or from the project is that the earlier you identify them, the earlier they start their first contact, then that gives them an opportunity to get to 8 contacts.
And there's an aspect of ownership also. You remember when you want to achieve something, if people or the community don't own it, then it will be a very difficult thing to do. So there is a leadership aspect whereby there is a proper leadership at the household, at the community health unit level, whereby the leaders, the leadership of that community or the work improvement team is giving directions on how to be able to achieve this. Of course, it's not only done through filling of the chart, but it's also done through other things. They can be able to track their commitment, that they are able to track every mother who gets pregnant, and they ensure that every mother is visited every month as per the notifications from ICHIS that Lynette has talked about. So there is all this lot of things that are surrounding achievement of.
So we're seeing this beautiful combination of digitization, then new manuals, so hand completed forms, and then work improvement teams, that ownership. And when all of that comes together, we're getting some kind of magic, I think, where you're getting proper integrated care, which is what we're looking towards. So I think on this note, I'd love to hear what your key messages are to our podcast audience of about how do we make every contact count. What are your key messages? So Lynette, you can start.
Yes, I think one of my key messages is that to make every contact count, then we need to strengthen the capacity of service providers, both at the community and the health facility. Yeah.
Okay. And I would want to say that normalize working between community and facility so that you can have this integration to achieve this to make actually this contact count, because it can only be done when these two work together.
Working together.
Yeah.
And the last one.
Communication and trust between the facility and community is actually fundamental in ensuring that we have continuum of care. Yeah.
Thank you very much for my esteemed guests. You clearly know what you're talking about, and this is grounded in lots of practical experience, but evidence-based as well. So it's been fantastic having you here today. I hope our podcast listeners have learnt from today's podcast, and we look forward to speaking to you again soon.
Thank you.
Thank you.
Let us do it now. No, no, no. Right now. Yeah. Right now. Right now. Let us do it now. Right now. No, no. Right now. Right now. Right now. Right now. Right now. Let us do it now, now. Right now. Right now. Right now. Right now. Yeah. Right now.